The third pathway that we'll examine is the spinothalamic system, a sensory pathway. The lateral spinothalamic pathway provides for perception and localization of pain as well as of temperature, because it has a somatotopic representation in the postcentral gyrus, as does the dorsal column lemniscal pathway, but its receptors, that is receptors of the lateral spinothalamic pathway, are sensitive to either damaged tissue, producing pain, or to temperature. In the neuro exam, testing cutaneous sensation with a cold or pointed object is a useful way of assessing sensory loss due to damage to either the peripheral nerve or damage to the central pathway. More commonly, cold stimuli are used because pointed objects, pins, used to be used, but they tend to have the possibility of producing damage to the skin. The sensitivity and spatial resolution for pain and temperature make this pathway an excellent modality for dermatomal mapping. Both the central and the peripheral processes of these cells in this pathway consist of thin axons, that many of them of which are unmyelinated, and some small myelinated fibers. The receptors are principally free nerve endings. The lateral spinothalamic pathway is an ascending 3-neuron chain, just as the dorsal column lemniscal pathway. Its centrally directed processes go in from the dorsal root ganglion, enter the spinal cord, and they immediately branch into small intersegmental tract, that is the tract of Lissauer, to synapse in the dorsal horn across 1 or 2 segments up above its input or below. The cells on which these primary neurons synapse are secondary neurons. They send their axons into the ascending pathway. Fibers of these second-order neurons decussate in the spinal cord. The decussating fibers enter the anterolateral portion of the cord and travel up in the lateral spinothalamic tract. The tract stays in that anterolateral position in the cord, relocates a little more laterally as they enter the brainstem, and finally the synapses on the thalamus and the ventral posterior lateral nucleus on third-order neurons. The axons of the third-order neurons project through the internal capsule to the postcentral gyrus of the primary somatosensory cortex. We see here the overall pathway of this system, and recognize that the fibers come in this case from the legs, and represented in blue, and they enter the dorsal horn. They might travel up or down in Lissauer's tract a couple of segments, but then synapse on secondary neurons which travel across the midline in the anterior white commissure, seen here, and then occupy this anterior lateral position and stay in that position all the way up through the spinal cord, and stay in a lateral position right through the brainstem until they get up to the thalamus, synapse in the ventral posterior nucleus of the thalamus, and from there neurons travel up to the postcentral gyrus. Recognize that the lateral spinothalamic tract, this decussation is at the spinal cord level, as opposed to the other 2 long tracts that we've looked at that decussate at the lower medulla level. The pain and temperature fibers, as we said, when they enter into the spinal cord, descend or ascend often a couple of segments, as seen here, just at the dorsal portion of the dorsal horn. And then they'll synapse on secondary neurons, and then at that point travel across to the secondary neurons, travel across to the midline, right near the central canal. So they're distributed over a number of segments. This distribution through the Lissauer's tract provides an important role of protective pain withdrawal reflexes. The synapsing of these fibers from Lissauer's tract is in these dorsal horn layers known as substantia gelatinosa and nucleus proprius. Recognize that the blood supply for this pathway is different at different levels of the pathway, so that the anterior spinal artery in the spinal cord provides support at this level in the spinal cord for both the anterolateral system and, of course, the corticospinal tract, which is sitting right here. So both of those are fed by the anterior spinal artery. The dorsal columns are not fed by that region. And as we get up to the brainstem, in the medulla, in the lateral medulla, we see the posterior inferior cerebellar artery feeds the lateral medulla, and the anterolateral system is in this lateral position fed by pica, the posterior inferior cerebellar artery. As you get higher up into the pons, represented over here, then there's another artery that feeds that region, and that's the anterior inferior cerebellar artery. And it's, again, a lateral portion of the pons. And we'll look at circulation for the brain in subsequent sessions. Note that the touch pathway mediated by this is crude touch, not fine two-point discrimination, which is provided by the dorsal column system. The overall lateral spinothalamic pathway is shown here, and we'll look at various levels after we look at this overview. Recognize the free nerve endings are prior to sensory input, dorsal root ganglion, then dorsal root comes in. Fibers may travel up or down one or two segments. In Lissauer's tract, synapse in the dorsal horn on a second-order neuron. The second-order neuron travels over to the other side within a segment or two. And then on the other side, it will stay in a lateral position, that is now contralateral, and it will travel all the way up in a lateral position until it gets to the thalamus, ventral posterior lateral nucleus of the thalamus. From there, it will travel through the internal capsule to synapse in the postcentral gyrus, again, in areas 3, 1, and 2 on the contralateral side from its origin. We see those pathways here, crossing at the anterior white commissure and then occupying this anterior lateral position and staying lateral all the way up through spinal cord and brainstem until it gets to the thalamus. We'll now walk through each of these levels and confirm the location of these fibers coming in the dorsal root. And we see Lissauer's tract, which will carry information for a segment or two. And then synapse on a secondary neuron, which will travel through the anterior white commissure to take a position in the anterolateral portion of the cord. As we go higher up, we see at the cervical medullary junction where the dorsal column nuclei have synapses for the dorsal column medial lemniscal pathway. There is no synapse for the anterolateral pathway seen here in green. It's far laterally and it will stay in that pathway, in that location. As we go into the medulla a little bit higher, we see that the anterolateral system stays very much lateral and very distant from the medial lemniscus and very distant from the pyramid. As we go a little bit higher into the pons, we see that the pain fibers stay in this lateral position, but now the medial lemniscus is moving out towards the spinothalamic pathway, and we see the leg is coming closer and closer to the spinothalamic pathway. As we come into the lower midbrain, we see that the spinothalamic pathway has stayed lateral, and the dorsal column medial meniscal pathway has come close to the spinothalamic pathway. So damage at this level to spinothalamic pathway is likely to influence also the medial lemniscus at this location. As we go higher up in the midbrain, we see that these continue in a lateral, both continue in a lateral position, the spinothalamic pathway as well as the medial lemniscus. And we see them up here in the midbrain. And then from the midbrain, we're going to go up into the thalamus, and we see a synapse on the third order neuron in the ventral posterior lateral nucleus of the thalamus. And from there, they will travel through the internal capsule to take a position on the medial surface of the hemisphere for the leg, and more laterally for the trunk, more laterally for the arm, and further laterally for the head. Notice that these all synapse in the post-central gyrus represented here, which is immediately adjacent to the precentral gyrus, where motor fibers are originating for those respective parts of the body. Lesions to the lateral spinothalamic tract in the brainstem or above, as with the other two long tracts, produce contralateral signs. So damage to the thalamus or to the internal capsule will produce contralateral signs in any of those long pathways. And particularly there would be contralateral loss of pain and temperature for damage to the spinothalamic pathway. However, in the spinal cord, these are very different from the dorsal column lemniscal pathway, and that is lesions in the spinal cord produce contralateral pain and temperature loss, just the opposite of what happens for dorsal column damage. This is because the decussation of the fibers in the cord is so close to the level of entry of the primary pain and temperature fibers. The sensory level produced by a lesion of this pathway also differs. It proceeds from the proximity of the lesion downwards, so that it is pain and temperature would be damaged if there is damage to the spinothalamic tract in the cord. But it differs in that the sensory level is contralateral to the location of the lesion, and the sensory loss starts one or two segments below the location of the lesion. That has something to do with the role of the Lissauer's tract. The effect of lesions in this pathway are summarized in this diagram, and they show that damage either to the cerebral cortex or to the thalamus or to the brainstem and to the spinal cord produce contralateral effects below the lesion. And if there's damage to the dorsal horn or to the peripheral nerve, there are damage and the symptoms are ipsilateral. The unique effect of spinothalamic tract lesions in the spinal cord are demonstrated here in that a lesion at T8 on the right would produce a sensory level starting at T10 on the left. This is because the pain afferents that come in the various dorsal roots would travel a couple of segments through Lissauer's tract, and therefore they might escape the impact of this lesion at T8 because fibers that are coming even in a T9 would travel in Lissauer's tract and only cross over above the lesion, so that even a person who have damage at T8 might have intact sensation on the opposite side all the way down to T9, whereas they would have a loss of pain and temperature on the opposite side below T10 because fibers that are coming into T10, although they might have traveled up a segment or two, they would be blocked when they got over to the lesion at T8. If there are any questions about this, don't hesitate to give me a call.